Natus Medical Incorporated and the Neonatal Care Academy presents Enhancing Family Experience During Phototherapy Treatment by Judy Moore. Judy Moore is a dedicated and experienced advanced neonatal nurse practitioner responsible for providing clinical education and product support for Natus Medical in her role as Director of Medical Education and Training. Judy also serves as an honorary lecturer on neonatal care pathways at Birmingham University and as instructor for newborn life support with the European Resuscitation Council. She also holds a postgraduate certificate in education of healthcare professionals. I'll now turn the presentation over to Judy.
Thank you, and welcome to our e-seminar on enhancing family experience during phototherapy treatment. We'll start by looking at our objectives of today's session. So today, we will understand basic facts on jaundice. We'll compare different methods of phototherapy delivery. We'll examine the incidence of readmissions to hospital for jaundice management. We will discuss the benefits of adopting family-centered care approach to phototherapy delivery. We'll look at the evidence related to fibre optic blanket phototherapy. And we'll discuss the implementation of safe home phototherapy practices. So, what are the basic facts regarding jaundice in the newborn? We all know jaundice is a common diagnosis in the newborn population. Approximately 60% of all term infants will develop hyperbilirubinemia. Out of this 60%, about 8 to 10% of those babies will require treatment. But unless it's pathological jaundice or extremely high bilirubin levels, that's bilirubin levels of greater than 30 milligrams per deciliter, these generally do not require NICU admission. Term infants with basic physiological jaundice can easily be cared for in community settings utilising phototherapy blankets. When we look at the preterm population, it's different. About 80% of all preterm infants will develop hyperbilirubinemia. And almost all preterm infants who develop hyperbilirubinemia will require treatment, which is generally provided in the NICU setting. Preterm infants may also require additional exposure of skin surface area to phototherapy light with decreased irradiance levels, and we'll discuss this situation shortly. If we look at the American Academy of Pediatric guidelines from 2004, they state that intensive phototherapy implies the use of high levels of irradiance in the 430 to 490 nanometer band, usually applied at 30 microwatts per centimeter squared per nanometer or higher, and delivered to as much of the infant's surface area as possible. They state that an alternative is to place fibre optic pads below an infant with phototherapy lamps above. When bilirubin levels are extremely high and must be lowered as rapidly as possible, it is essential to expose as much of the infant's surface area to phototherapy as possible. It's important we remember these guidelines relate to full-term infants. Another paper described an approach to the management of hyperbilirubinemia in the preterm infant of less than 35 weeks gestation. In this paper, they made some specific recommendations. Firstly, to increase the irradiance by bringing the lamp closer to the baby. It's very important to remember to follow specific manufacturer guidelines relating lamp distance to babies. Please follow specific recommendations by your manufacturer on how close lamps can be placed to each individual baby. The next recommendation was to increase the surface area coverage by placing light sources underneath infants, such as fibre optic blanket phototherapy. They also recommend that irradiance should be checked frequently, and to use the radiometer recommended by manufacturers. This paper recommends that in infants of less than 1,000 grams, we should start phototherapy at lower irradiance levels, and additional phototherapy should be provided by increasing the surface area exposed. They call out at this point that halogen and tungsten lamps should be avoided because they cannot be placed closer to the infant due to the heat emissions from such lamps. Bearing in mind these infants of less than 1,000 grams, it's important to remember that these very tiny, immature infants have gelatinous thin skin, through which light will penetrate readily, reaching more deeply into the subcutaneous tissue, and there is some evidence that phototherapy can produce oxidative injury to cell membranes and DNA, and such injury can have a negative effect on such infants. So let's examine the treatment for hyperbilirubinemia. The US Preventative Task Force from 2009 states that phototherapy is a common treatment for hyperbilirubinemia, and they found a lack of evidence pertaining to the harm of such treatment. However, they did call out some potential side effects that we all know for babies who are being treated from jaundice, and these include potentially weight loss, gastrointestinal problems, but more importantly, the interruption of breastfeeding and the disruption of the maternal-infant relationship, which is a very important part at this point in the newborn's life. In 2007, a study was published that suggested a linkage between hospital-based and community-based services that would reduce the risk of neonatal jaundice complications. They stated coordination of services improves monitoring of infants through follow-up care, for example, some home health type services, can reduce hospital readmission rates, and can reduce costs related to such hospitalizations. So let's think about these readmissions to hospital. And does a shorter length of stay after birth actually influence readmission for jaundice management? Numerous studies have reported that the length of stay for childbirth has been steadily decreasing in recent decades in an effort to decrease costs and to demedicalise pregnancy. But this can lead to increase in hospital readmission, with approximately 50% of neonatal readmissions attributed to jaundice management. Lane et al. In 2015 demonstrated that infants born at less than 38 weeks gestation and discharged between days 0 to 2 were 9 times more likely than those born at greater than 39 weeks with a length of stay to 3 to 4 days to be readmitted for jaundice management. Young et al. In 2012 demonstrated that both feeding problems and jaundice were the most frequent cause of hospital readmission in the first 28 days of life, with an estimated mean cost of $4,548 per readmission. From the perspective of parents, physicians and payers, an unplanned and unexpected readmission within a few weeks after discharge of an otherwise healthy newborn from a Well Baby Nursery is an undesirable event. This leads us to understand that we have a need for jaundice screening programs, both in the hospital before discharge and in the community setting. It helps us understand we have a need for phototherapy in lots of different care areas, not just the NICU, the neonatal environment and the Well Baby Nursery, but potentially also in the emergency room and in the paediatric units. And finally, it demonstrates to us the need for community-based phototherapy programs. So let's examine outcomes with different phototherapy devices. This study was published in 2013 in the Journal of Perinatology, and they examined the efficacy of phototherapy devices and outcomes amongst extremely low birth weight infants. It was a multi-centre observational study. They examined 1,974 extremely low birth weight infants who were treated with either LED spot phototherapy, fluorescent bank phototherapy, or fibre optic blanket phototherapy. This study demonstrated that infants who were treated with fibre optic blankets were at a lower risk of patent ductus arteriosus, PDA, and PDA or death compared with those who were treated with other phototherapy devices. There was also a decreased risk of necrotizing enterocolitis with fibre optic blankets compared with spots. So the question has to be asked, could there be different physiological effects for an extremely low birth weight infant lying on their back on a fibre optic blanket versus an overhead phototherapy lamp? There have been trials showing a hemodynamic effect from phototherapy. In a small randomized trial with chest shielding during phototherapy, they showed that it reduced the frequency of PDA and the length of hospital stay. Benders et al. Has also shown hemodynamic changes in both term and preterm infants whilst on phototherapy, which resolved when phototherapy was stopped. Fibre optic blankets in this study also had a decreased risk for mental development index of less than 85 compared with LEDs. However, the authors do not have a plausible biological theory to explain these findings. The differentials were not hypothesized before the study, and due to the large number of comparisons performed throughout this study, this could of course be due to chance. So let's look at the history of fibre optic phototherapy. When was it first used? Well, fibre optic phototherapy was first described in literature in clinical settings in the mid-1990s. And at this point, it was comparing the efficacy compared to conventional overhead white and blue fluorescent lamps. At this time, fibre optic phototherapy was summarized as an approach representing a promising way to aggregate synergically the most recent optical technologies and develop a modern, efficient, and caring phototherapy system for low birth weight infants of greater than 1,500 grams. What we have to remember is that these studies were performed in the 1990s. None of the lamps examined at this point in time were LED phototherapy, which did not come into our clinical settings until the early 2000s. Family-centred care is a very hot topic in neonatal care today. Everything we do within neonatology, we try to adopt into a family-centred care approach, and phototherapy also is included in this remit. The American Academy of Pediatric Clinical Practice guidelines strongly recommend that clinicians promote and support breastfeeding for jaundiced infants. In this paper published in Pediatrics in 2013, they present a very nice case report reflecting this common clinical scenario in neonatal medicine, and describe a technique for providing phototherapy whilst maintaining evidence-based practices. In this case, they prove that effective phototherapy treatment can easily be achieved within a family-centred care framework, even if the infant is extremely jaundiced. And this can be seen very nicely in the picture to the left of the bottom, where you clearly see a mother who's lying with her baby on her chest on a phototherapy blanket with an overhead phototherapy lamp on top. So the paper published very nicely that this approach can assist clinicians in providing best practices and family-centred care. What's also important to note at this point is that in scenario 1 on the left, where the baby is receiving phototherapy overhead and underneath, the baby's eyes are clearly protected by eye protection such as a billy band. This is because there is direct light shining down onto the baby and into his eyes. In the second scenario that we see to the right, we see a mother who is breastfeeding her baby whilst receiving phototherapy treatment from a blanket. In this scenario, the mother has the blanket where it is positioned in a place it is not shining directly into the baby's eyes. Here, the eye shields can be removed and the mother and baby can make direct eye contact and facilitate that important bonding and attachment process. So let's consider bonding and feeding during phototherapy. As we mentioned, encouraging breastfeeding is important in jaundiced infants. Skin-to-skin contact is the natural habitat for human infants, and when separated from this contact, infant stress hormones increase and they cry. By providing phototherapy on the mother's chest, this response can potentially be avoided. Fibre optic blanket phototherapy can help to continue exposure to therapeutic light whilst at the same time promote bonding and attachment during feeding, and this can be very nicely seen and demonstrated in the picture to the left. It's also important to consider the nurse's experience. This was a very nice study that looked at nurses' experience of conventional versus fibre optic phototherapy. Fibre optic blanket phototherapy devices, such as the NeoBlue blanket, can help to increase parent satisfaction during phototherapy treatment. It is well documented, as we've stated, that infants display discomfort whilst under conventional phototherapy, and parents are often distressed to see their infants showing signs of discomfort. Fibre optic blanket phototherapy use can lead to increased infant comfort and satisfaction and increased parent satisfaction by facilitating bonding, breastfeeding and kangaroo care. Nurses potentially may be concerned about the possible harm and discomfort to the eyes and skin of infants when they're nursed under conventional phototherapy. When efficacy was considered in this study, nurses preferred blankets compared with conventional phototherapy because of the ability to facilitate infant comfort and parent-infant interaction. So how can fibre optic phototherapy prevent readmission for hyperbilirubinemia? This study, published in 2013 in the Journal of Investigative Medicine, did a retrospective review of readmissions to hospital with a diagnosis of hyperbilirubinemia between two hospitals from January 2010 to September 2011. They collected data on birth demographics, weight changes, intervening medical visits, feedings and elimination. In 21 months, 176 infants were readmitted to 2 NICUs for the management of hyperbilirubinemia. And the conclusion of this study was that these preliminary data suggest that a large number of infants are readmitted for hyperbilirubinemia and that nearly 1/4 of them may benefit from home management. They found that discharge bilirubin values when compared to the AAP threshold were a better predictor of bilirubin upon readmission than the isolated values for the bilirubin risk zone. One of the things that we always bear in mind in neonatology is ensuring that we get best parent satisfaction. This study looked at preparing discharge and maternal satisfaction versus newborn readmission for jaundice, and they were looking at the difference between postpartum models of care. So the aim of the study was to identify the model of postnatal continuity of care most likely to prepare mothers for discharge and to reduce infant readmission for jaundice and enhance maternal satisfaction. In the study, all mothers had normal vaginal deliveries and were discharged less than 60 hours of age. After discharge, a telephone survey was conducted and infants who presented with signs of jaundice were identified through statements from their mothers. After these studies were conducted and they identified the infants who potentially needed treatment, they were split into two groups. One group who's cared for completely within the community, and a second group who were readmitted to hospital for treatment. The community-only base model featured a high level of maternal satisfaction, whereas the mixed hospital model, where mothers came back into hospital with their infants for treatment, found that mothers reported signs of jaundice significantly more often once they were back under care of the hospital. Phototherapy was offered in the home-only model in the region, operating under a mixed ambulatory model, and in this region there were no readmissions for jaundice recorded. Again, this study looked at reducing parental stress. They looked at the effect of home-based phototherapy on parental stress in mothers of infants with neonatal jaundice. Same hypothesis they stated is that hospitalisation of an infant in the first days following birth is one of the most stressful events in the life of parents. In this study, 64 infants were randomly divided into two groups, home-based phototherapy and hospital-based phototherapy. Parental stress scales were given to parents and maternal demographic data was captured. Mean maternal stress scored before intervention was not significantly different between the two groups. However, after the intervention, meaning one group of babies cared for at home, one group of babies were cared for in hospital, after the intervention, the mean stress score in the home-based phototherapy group was significantly lower than the hospital-based phototherapy group. So the conclusion from the study was home-based phototherapy can be considered as a suitable strategy for the treatment and prevention of infant readmission by reducing parental stress. So when can home phototherapy be considered? Well, home phototherapy for hyperbilirubinemia is considered medically necessary if all of the following criteria are met. Firstly, that the infant is otherwise ready to be discharged from the hospital and the only thing that would keep them there would be jaundice management. That the infant is eating, voiding and stooling well and is alert. That a primary liver disorder is not the cause of the elevated serum bilirubin. That the total serum bilirubin is less than 20 to 22 milligrams per deciliter in term infants, or less than 18 milligrams per deciliter in preterm infants, and that follow-up evaluations will be performed by the physician or by home nursing visits. This is another document that specifically looks at home phototherapy devices for neonatal hyperbilirubinemia. This document addresses the use of home phototherapy and devices used for the treatment of neonatal jaundice that is physiological. That is, it means it's non-pathological in nature. We all know in utero, the fetus requires larger amounts of hemoglobin for oxygenation, and after birth, the need for this is reduced. Therefore, the haemoglobin is rapidly destroyed, and this is what produces the increased levels of bilirubin. Neonatal jaundice is a common occurrence and is frequently treated in the home setting. Infants with very high levels of bilirubin may be managed in the inpatient setting, which would allude to the study that we looked at earlier, examining those cut-off threshold levels for bilirubin for treatment at home. This study came from the UK, examining again home phototherapy. Is it a feasible, safe and acceptable practice? They documented that home phototherapy is indeed a safe and feasible option when implemented with risk assessment protocols. The home phototherapy service provided a high level of parental and midwifery satisfaction. The service had a minimal impact on community workload, and the programme transferred care from the hospital to the home, reducing the length of hospital stay for some mothers and their infants. This study also, which was published actually as far back as 1985, looked at a home phototherapy programme using fibre optic blankets. They examined healthy term infants with hyperbilirubinemia, and they compared the results with a group of term infants who met enrolment criteria but were treated in hospital. In the home phototherapy group, no parents reported significant complications and no infants required rehospitalisation. Bilirubin levels decreased as rapidly in the home group as in the hospitalised control group, and the duration of treatment averaged 2.8 days. The study demonstrated that approximately $18,000 was saved by treating these 62 infants at home compared with in-hospital costs in the community. And therefore, home phototherapy was again found to be feasible, safe, and an effective alternative to in-hospital phototherapy for otherwise healthy jaundiced infants with motivated and capable parents. This was a very nice article that was published very recently at the beginning of April 2019. It was actually a newspaper article that gave a case study of a set of twins. And these twins were born at 34.5 weeks gestation, were cared for in hospital for the first 5 to 6 days of their life, but were well, they were feeding, they were not losing excessive amounts of weight, and the only reason to remain in hospital is that twin 2 required phototherapy. Parents were very motivated, very capable, and therefore the family were discharged home under the care of the community with a phototherapy fibre optic blanket for the second twin who required continued phototherapy treatment. The outcome was great. These babies remained at home with their family, and after 2 to 3 days of phototherapy treatment, the second twin also discontinued the use of the fibre optic blanket phototherapy. Well, it was a great example of exactly why home phototherapy can be enhanced in a family-centred care approach. Home phototherapy really has been accepted globally. There are many examples of phototherapy programs that are being run in communities throughout Europe, throughout Asia, and throughout North America. One example from the United Kingdom examined what's actually required before setting up such a program and how to measure the success. In this paper, they described how they introduced the service and how hospital and community midwives undertook training covering inclusion criteria, treatment protocols, equipment use, and the assessment of parental competence. The protocol conditions included a daily capillary serum bilirubin level, the discussion of the results of these bilirubin levels with paediatricians, basing treatment on these serum bilirubin levels along with the age of the infant, and a serum bilirubin level measured after discontinuing phototherapy. Parents also underwent a 1-hour training session on equipment use, advice on feeding, skin care, and temperature control of the infants receiving phototherapy at home, and they were also given written advice. Community midwives spent approximately 60 minutes on the first home visit, initiating the phototherapy treatment. Subsequent visits were shorter. Poor compliance without compromise to either infant were identified in 2 families and rectified quickly. No other adverse incidents were reported, and there was no equipment failure. When evaluating, all of the parents preferred home fibre optic blanket phototherapy to inpatient treatment, and community midwives have been happy to continue this programme since. So in summary, what have we learned? Well, we've learned that fibre optic blanket phototherapy is a safe, feasible and effective way of managing physiological jaundice in newborn infants. Phototherapy delivery using fibre optic blankets can help to enhance the infant-parent bonding and breastfeeding practices, and may be used without eye protection when held in positions so that eyes cannot be exposed to the light. Blanket phototherapy can also increase surface area coverage of light in extremely jaundiced infants when used in conjunction with overhead phototherapy lamps. And blanket phototherapy or home phototherapy under controlled guidelines can be a safe and feasible way of continuation of family-centred care and reduce hospital readmissions for physiological jaundice. For anyone who's interested, here is a reference list of studies that have been cited throughout this presentation. Thank you.